Bulavinaka once again, everyone. Try and how do I have to share? Okay. Sorry. Just bear with me. Yes, wrong. Hold on. How do I minimize this? I'm so okay, wait, just give a minute. Oh, sorry. I'm trying to wait, not share.
You see the share screen button at the bottom.
Yeah. So I can press share and then maybe this. Yeah. What do I minimize? Okay, hold on. Minimize this. Okay, this one. And this one. Yeah. Oh. Then close this one. Open system. Cancel. Just make it big. Really? Okay. Okay. So I'm so sorry, people.
Okay.
There. And then
Go.
There.
Here.
Yeah. Is that all?
Oh my gosh. How do I get to Zoom?
And
Do you want me to share it from my computer, Veri, and then you can just talk? Or have you you've got it too? Have you, Felicity?
I did some editing.
Extra stuff. Okay.
Yes, just this morning. Just
You minimize this.
you can't see my screen right now, right?
No, we can't.
Oh man. Okay, hold on. So open Zoom and then share. Maybe share. Open system.
If you'd want to share the updated version by email with either me or maybe Rachel, like we could also share it.
And the problem is it's not my okay. Maybe I'll just ask Felicity if you can just open from yours. But then I'll
Is it the one that you sent me earlier?
yes.
Oh, okay. Give me just a second.
Oh man. Where am I? Hey, where? Hold on. Where am I? My God. Did I just
We can
What?
still see the
Oh, okay. Okay. Can it go into like one? This is the one.
control.
Oh. Okay. Sorry. Apologies for all the hiccups. Anyway, today I'm going to present on an interesting case that we haven't really found the answer. Just a heads up for you guys. An interesting case that was operated on a few weeks ago. And I hope to learn from the forum today. Maybe next slide. So a brief clinical history on the case. This is a 61-year-old para 4 who's a known hypertension and also recently got stroke. and also has a tube inside to a peg inside to in for the recent stroke that she had. Initially, she had an ECOG of 1. And the reason why she initially came to gynae clinic was because she had the complaint of a postmenopausal bleeding. The duration was not given to us. So that's why I left it like that. On examination, patient was stable. The only remarkable finding that was initially was that of the limbs. He had a right hemiplegia. And according to the gynecologist who saw her on speculum, they said that the cervix was very posteriorly placed, and they could not identify the cervix while doing the speculum. And on VE, they could feel that the cervix, the uterus was bulky. Otherwise, the cervix to them felt normal. And as per the blood results, she didn't really had anemia. Otherwise, she had just a little bit of creatinine issue. Otherwise, everything else was remarkable. Can we go on to the next slide, please? So the image that is there is from the first sample that was labeled endosample. As you can see, there's another image that was supposed to be there, but unfortunately, it couldn't get through. But anyway, from the sample that we can see, we can appreciate that there are blood in the background with some normal endocervical fragments that are seen. However, you can really appreciate the sheets of malignant tumor cells that are present around, which are in solid sheets. During the initial biopsy, we thought we did not really see the normal or glandular endometrial tissues there. However, the specimen with the tumor that was there, it was mostly high-grade tumor cells that didn't really form glands or didn't really show a lot of intercellular bridges or things like that. There were some areas that we thought were attempting to form glands. Therefore, we thought, based on the nuclear features, we thought we were dealing with a high-grade endometrial carcinoma, because I think in some areas we were seeing some degree of squamous differentiation, and thinking since the sample was supposedly coming from the endosample, that's how we were thinking. So for us here, we have some basic immunohistochemistry. We wanted to rule out the stromal, if they had any stromal elements on this tissue. So the next slide should be next. So we did some immunostains. So CK was strongly positive, whereas our ER, PR, and also CEA were all negative. Based on that, we came up with the impression of a high-grade endometrial carcinoma. So the surgeons were being alerted. I mean the gynecologist. So next slide, please. So this is just to show our initial report. Next slide. Okay. I must apologize first for these images, because these images were taken after our initial cut. But because we had to go back because the case was interesting one, therefore we went back. And many thanks to Dr. Philomena, who's also listening, for her hard work. Anyway, as you can see on the first picture, which is labeled 1, 2, 3, this was the TAH and BSO sample that was given that was received from the lady. If we are to increase the size of the, is it possible to increase the size of, yeah.
Increase the size of the image.
Yes, please.
I don't think I can do that from PowerPoint.
Oh,
Sorry.
yeah. Okay, so if you really have good eyesight, unlike me, this is supposed to be the ectocervix in here. And then you have the endocervical area. And then once you come into here, where supposedly the transitional zone, there is a tiny polypoidal tissue that is whitish in color in here. And then on initial cut, according to Dr. Philomena, she didn't really see any mass within the cervix. The mass that she saw was mostly centered around the TZ zone. And then what was obvious was the endometrial polyp that had involved by a mass which had extended throughout the uterine wall up to the fundal area. And this mass didn't really seem like a tumor initially. She actually thought they were more of a fibroid on the initial cut. So this other image, the other image of the same tissue, and you can see that you can really appreciate the discoloration, which has started from the stromal, the ectocervix, the stromal cervical stroma, and extend throughout the entire uterus, as you can appreciate in here. And on the third image, you can see that this mass, the discoloration has nearly abutting the serosa on the fundal area. So quite an extensive tumor. Okay, next slide, please. Oh, next one. Oh, man. Oh. So from the microscopy, as I had alluded earlier, the cervix didn't really feel abnormal, but then you see that there is florid SYN3. And then when you reach the TZ, there was an endocervical polyp that was present, which had this papillary structure on one side. And this, however, had eroded into the cervical stroma. As you can see on this picture as well, these malignant anastomosing, or maybe looks like more like a bulldozing or anastomosing cause of malignant squamous cell. Can we go to the next slide, please? On the endometrium, we appreciated an endometrial polyp. Apart from the endometrial polyp, there was this small foci of malignant tumor cells. And the morphology, which is similar to the one that we saw from the endocervical area. A more high power image of those cells, you can see the degree of nuclear pleomorphism. You've got the bizarre cells on one side, and you see that apart from the necrosis, you see that the cells shows marked nuclear pleomorphism. There is hyperchromasia, cross-chromatin, and a lot of mitosis. Next slide, please. And the tumor cells, as you can see, it had infiltrated throughout the myometrium, reaching up to the fundal and the serosal areas, there were a lot of lymphovascular invasion, which was more apparent in the cervical stroma and the LUS area as compared to the other parts of the uterus. And there were areas showing squamous, the keratin pearls. Next one. Next slide, please. So we are still in a dilemma where is the primary and what is the answer. So we repeated our immunos just to be sure. And from the endometrial region, which was still yielding the same, ER, PR, CEA were all negative. Next slide. So the discussion today is whether the tumor that we are seeing in the cervix is the primary versus an endocervical SCC with fluorescein 3. Unfortunately, I'm quite unsure on how we will be measuring our size and our depth because of the nature of the tumor. And also from the endocervical area, there was apparent SCC, which was coming from an endocervical polyp. And it had infiltrated throughout the myometrium. Otherwise, ovary and fallopian tubes were unremarkable. And our pathological staging for now was P2TB. We could not really assess the node or the metastasis. So with a staged group of stage 2B. So we've got a few differential. Next slide, please. Whether this tumor is SCC arising from endocervix, the possibility, or whether it's coming from the endometrium. Could this be verrucous carcinoma of the endocervix or the endometrium or others? Because one thing for sure is that the gynecologist will be bothering us onto the primary because management is determined by the diagnosis that we give. Next slide. So the questions that I want to ask the forum is, if this is, like I've alluded to earlier on, and what further tests can we do in here? And in our setting, if I see cases in the future, will it be advisable to do further testing as what we have done right now? And what is the available treatment options that are available? And also I would like to ask, or I would like to learn more about the measurement of this kind of tumor and the depth when we don't really see florid SCC from the cervix. How will I be able to measure and to find the depth? So basically, those are the questions that I want to raise in this presentation. I think that's about it. Next slide. Yeah, thank you. I hope I don't get everybody confused.
Thank you. Do we have any answers or comments to any of those questions?
So Barry, can I ask a question? Just because I was struggling to appreciate the macro elements as you were describing them. Is there any disease in the cervix? From what you've told me, there is, but it's primarily within the endocervix. Is that right?
Yes.
Endocervix.
Yes.
So the
That's right.
ectocervix is uninvolved by the malignancy, but the SYN3 involves a transformation zone and
Yes.
Yeah, but out on the ectocervix and what you saw macroscopically of the cervix looked normal. So it's all the diseases in the canal extending up into the uterus and then permeating the myometrium through to the or abutting the serosa. And what about the parametria? Are the parametria involved? Like the soft tissues outside of the cervix?
No. The parametric is apparently unremarkable.
Okay.
But but there's a lot of LBS side and around it, but it's not extending outside, yes.
And did the surgeons give you any ideas about whether there were palpable lymph nodes intraoperatively, whether there was lymphadenopathy that was suspicious?
Dr. Una, I see Dr. Una listening right now. Maybe Dr. Una can help?
Hi, guys. Sorry. No, intraop, we could not palpate any lymph node. There was no palpable lymph node.
Yeah. Okay. So it's probably confined clinically, but no parametrial involvement, but a lot of deep myometrial invasion.
Yes.
Yeah.
Just looking at your macro pictures, though, Vedi, you might have already cut it off. But Una, did you do a simple hist or a rad hist?
Simple hist.
Yeah, because I couldn't actually see a lot of parametrial tissue on that specimen, but it did look like it was getting really close to that stromal margin around the cervix. But to me, the parametria is that kind of soft stuff that's adjacent more to the cervix rather than up around the fallopian tubes and things. But when you do a simple or a laparoscopic hist, sometimes you get very little parametrial tissue at all with the specimen.
Yeah. So one of the, I mean, it sounds like everyone's in agreement on the morphology that it's probably a squamous cell carcinoma, quite poorly differentiated with quite significant atypia. Is that fair? Is squamous cell carcinoma, that was your main, you had differentials in terms of the site of origin, but you thought SCC was, and you've got keratinization, and you've got some intraepithelial neoplasia as well, SIM3. So I think when you're not sure where the tumour has originated, you sort of have to go back to first principles. And one of those is looking for a precursor lesion. And also looking at the odds, what's most likely. And in this context, if you've got SCC involving the cervix and the endometrium, and you've got a precursor lesion in the cervix, and we know that SCC in the endometrium is vanishingly rare, and is sort of a diagnosis of exclusion. And to make that diagnosis, part of the requirement is that there's nothing in the cervix. So putting all that together, even though the bulk of the disease is up in the uterine body and deeply invading the uterine corpus, what do you think is more likely to be the primary? I know it's a bit kind of counterintuitive, but I think
I'm not sure how likely is the endocervical SCC.
Yeah, well, the transformation zone is the usual site of origin of neoplasia. That's where dysplasia starts, and that's in an older woman usually in the canal because it migrates upwards into the canal. So I think the lack of disease on the ectocervix doesn't mean it can't be, and the normal looking ectocervix doesn't mean it can't be a cervical primary. And the fact that you've got the precursor lesion in the cervix as well supports that. I think the critical thing here would be to get HPV testing or P16. I think that would probably, definitively sort it out once and for all.
I was going to ask Una, has she ever had a cervical smear test or HPV testing done? You're on mute.
Oh, sorry. Her previous smears were normal, but she's never had any HPV testing done on those smears. But that was how many years ago? Not recent, though.
Yeah. I don't know if Rachel and the other mentors agree, but I would regard this as most likely originating in the cervix with extensive upward extension and deep invasion of the myometrium. I think the alternate possibility of it being an endometrial primary growing down is a possibility, but to make that diagnosis, we can't, in the context of cervical involvement, make a diagnosis of an endometrial SCC. That diagnosis requires that there's no disease in the cervix, because cervical SCC is overwhelmingly more common and more probable. I think what's odd here is the pattern of tumour distribution and the fact that it's appearing to originate higher up in the canal. And so it's presenting more like a uterine primary in terms of its presentation and pattern of spread or invasion. What do you guys think? Is it?
Yeah, I totally agree. I think sometimes the small biopsy can be difficult because squamous cell carcinoma sometimes degenerates in the middle and it ends up with a kind of pseudoglandular look. So you're looking at this really poorly differentiated tumor and you think, oh, that might be a bit of gland formation, but actually it's not. It's just SCC that's degenerating. And if you have a look at other SCCs that you might come across your desk, like in the skin or something like that, when you get really big kind of expansile SCCs, they can get a pseudoglandular look, which is a bit confusing. Deb?
I agree too. I think the what we find here with the HPV, where we begin the HPV testing, is I find the HPV 16 cases do seem to almost preferentially to be up that canal, where if the tumor starts in squamous metaplasia, then you do get a squamous lesion, or you get those very, very ugly tumors. But what it does is it really explains the clinical. So if you're getting negative smears, but that tumor is up the canal, it might be that the smear just never got to the lesion, which is unfortunate. Yeah.
I think it's a tricky question in terms of staging.
Yeah, that was my thing, because I was wondering about the 2B, Vidi, because if you regard it as a primary cervical SCC, then a 2B on the basis of the parametrial extension, but it's quite hard to see in this case. And it's funny, you think, oh, it's going all the way up into the uterus, that makes it terrible. But the staging system for cervical cancer doesn't matter if it goes into the uterus. So you really want spread beyond to make it worse. So, vagina, lower third of vagina or nodes or definite parametrial extension. But I mean, I agree, it looks very ugly.
And with all that LVI, it's worrying that, there's probable metastatic spread to the lymph nodes, or that would be very of concern.
So in this kind of case, can I ask a question? Like, how will I measure the depth and the size? I just use the entire extension, or?
Do you have any invasion in the endocervical canal?
Yes.
Okay, so that you can at least measure that depth.
Okay.
But I think it's, and is it going through the whole wall of the endocervical canal?
Yes.
Is it? Are you
Majority
able to?
of the endocervical is infiltrated with this tumor.
Okay. So that's probably a measurement that I think you can give in terms of the depth of invasion in the cervix, and then maybe an overall maximum dimension of the tumor.
Okay.
I don't know. This is a bit outside of the realms of what we normally see. I think
sometimes
that
clinical or radiological appearances are easier in this case, and you actually are allowed to stage based on radiology or clinical. Although I guess she didn't have any pre-op. What pre-op imaging did she have, Una?
She had a CT scan.
Yeah. Okay.
Can I argue devil's advocate and suggest that by the time it's in the uterus, the measurement in the cervix is becoming like overturned by the fact that you've already gone up a stage? Or have you?
Yeah.
You're greater than 4 centimeters.
More than 4 centimeters, and that's the
Yep.
critical number.
Yeah. So from a
Mm.
staging perspective, a lot of that measurement and the detail there is for the lower stage tumors.
Yeah.
I think the thing that I think the clinicians may be interested is knowing the distance to the margins around that cervical stump to know whether those margins are clear and by how much, because perhaps that would influence management if there is options for management.
And that would also give you an idea about the status of the parametria. If it's actually going to the outer reaches of that excision, then you'd be concerned the parametria are involved as well.
Do you want, Felicity, do you mind? Can you flick Verdi's presentation up again? And we'll go back to the pictures of the specimen in the bucket that Philo took. And I think it just does show that cervical stromal margin there.
Can I ask why this is coming? Do you have P16 in Fiji?
No, we don't. Very?
No, we don't, unfortunately, but we are trying to get it.
Yeah, it's really useful. I think it's a great stone.
I think particularly in your setting where you don't have HPV testing or very frequent smears, I think that if you had a wish list for immuno, for me, that would be next top of your list.
Which image did you want me to pull up?
The pictures of the specimen that are in the bucket, the gross macroscopic pictures. Keep going. Stop. Yeah, number 6. Thank you.
If you don't have it in presentation mode, can you zoom in? Like if it's in just like edit mode?
Oh, you can. That's great. Yes,
Yeah.
and pull it down a little bit. So that's what I was. Oops. Oh, okay. To me, does that look? I'm not sure. It's just disappeared off the top of the screen now. The middle picture. Is that Philo? Is that the coming to the edge of the cervix there? It still just disappeared off the top. There we go. Perfect. Yeah. Is that a cervical margin, Judy?
Yes.
Yeah. Yeah. So to me, it looks like it's getting really close as you come more proximal. And there's not a lot of parametrial fatty tissue or anything to be sure whether it's going into that, but presumably, Una, you'd have there was a bit of a plane there for you to get around.
Yes, Dr. Rachel. For her, she had MRI that was done also, and on the MRI, they could see an endocervical mass, about 7 centimeter that's there. They actually measured 7 centimeter on that MRI.
Great. Well, there's your staging then.
Yeah, totally.
And I was wondering,
Sorry, I've completely forgot about it.
and any lymph nodes on the MRI?
No lymph nodes on the MRI. There were sub-centimeter ones, but no big ones.
But no enlarged. Okay.
So I would be taking some sections through just at that soft tissue, that interface there, right at the bottom of the picture. Probably can't see. Yeah, just to check how close that tumor gets to that margin there. So yeah, so just where the tissue starts expanding out and heading up into the uterus. Yeah, and now it's at the very top of the screen. I if you haven't already, that's where I'd be taking sections to look for extension out onto that paracervical soft tissue margin. Do you feel like you've sampled that well, Verdi, that area?
Yes, we managed to load all of the cervix, including whatever that was around it. See, the third photo is actually the cervical mucosa with some discoloration.
Mm-hmm.
And so all of that was also loaded, including that painted area on the more radial margins. So those were all taken as well.
Okay, so it sounds like you've put lots of blocks in, which is great.
I was just thinking,
So the margins,
David and Paul are still there. Could you give them a block? I could do a P16. They could bring a block home. I don't know if they can do that, or some blank sections.
I think Una, they've gone, eh?
No, they are here. They're leaving at 4 p.m. If you
Oh.
guys prep it, I can give it to them. They're coming up to hospital again at 2 p.m.
Oh,
Yeah,
great.
just
Thanks,
Perfect.
if
everyone.
you can. I don't know how you go bringing a block of tissue through customs.
Oh, Rachel,
Oh, they
There's
know
a
how to
standard
bring it. I
letter.
think
I do it all the time.
You do it all the time.
Yeah, there's a
But
standard
if you want
letter.
to send, if you want to send a block home with them, I can do some stains, which will help.
thank you. We will do that.
Yeah. Yeah.
Thank you.
Thank you so much.
So I guess what can we learn from this? What can we take away? I think when you've got a tumor where you're comfortable with what the histotype is, but you're not sure of where the site of origin is. What are the elements? What's the information that helps you make a decision about where it's begun? That's probably the major teaching point here, I suppose. And what clues are there in this case about where the most likely site of origin is?
The precursor lesion on the cervix would be one.
Yeah. Yeah. That's probably the best thing you've got in this case. And then probabilities. The fact that an endometrial primary squamous is vanishingly rare and can't be diagnosed unless you've excluded a cervical primary. But it's always, you always think about that possibility if you see it in the uterus, but yeah, it's far less likely.
And there's usually other history things that help you with that, aren't there? Because it is so unusual. It's usually associated with cervical stenosis and ongoing infection or hematometra or something like that.
Yep.
So you'd have a slightly different picture.
Yep. Or I guess it could be, one of those endometrioid adenocarcinomas where the squamous component has become neoplastic and overgrown. But to make that diagnosis, it'd be nice to see a bit of endometrial adenocarcinoma component and an absence of a precursor lesion in the cervix, which appears centered around the transformation zone, which all sort of stacks up for the site of origin. It's just odd in this case that it's grown up instead of out. Yeah.
I have your case reminded me video. I have something that's kind of similar. I have a very quick case I could just share in the last 10 minutes if you want. So this is another postmenopausal lady with some postmenopausal bleeding. Let me just get it in focus and then I'll share my screen with you. 1 second. Okay. Share. Here we go. Can you see that now?
Yeah.
Yes. Okay. So these are endometrial curettings, and there's a lot of blood and a few collections of endometrial glands around, and they're crowded and atypical, back to back. Sorry, trying to focus. And a few mitotic figures. And there's quite a lot of tissue like that around, with some benign background endometrium as well. And then scrolling around, we see something else. Oop, more solid sheets. And these are starting to look a little bit like your case, aren't they?
Mm.
So we had a similar differential. Is this a squamous differentiation in an endometrioid adenocarcinoma, or is it coming from somewhere else like the cervix? And we were very suspicious that it was cervix in this case because of the morphology. They look like they've been stripped off the surface. It's just squamous in that component. And normally when you get squamous differentiation in an endometrioid adenocarcinoma, you get rounded morules or little keratin pearls. They just look a bit different. This lady was very underscreened. Again, hadn't had a smear or an HPV test for a long time. But we were lucky enough, we have P16. So the background endometrium's got this very strong but patchy mosaic type pattern of staining, which is really a wild type pattern. And then in this little focus here, you can see it just lights up these strips of cervical squamous epithelium. Very strong nuclear staining, very dark. It's what we call block-like positivity, where almost every cell is completely dark brown. And at the time of the papel, she did have a cervical smear test and an HPV test done, and she had HPV other, and they saw SYN3 on the smear. So she's going to theatre next week, and instead of just having an operation, we're doing a quick urgent MRI to see what's actually happening in her cervix and does she also have a cervical cancer. But I thought that was quite a nice example, similar to yours, but hasn't got quite as far, hopefully.
Mm. Nice.
So can I ask a question, Dr. Rachel?
Oh, hi, Lucy. How are you?
I'm good.
Good.
So for your case, what will you sign it out then? Will you write a comment? Or will you wait
Yes.
for a hysterectomy?
No, so we signed it out as endometrioid adenocarcinoma, and we did our little pro forma for that with our standard panel of immunohistochemical markers. And then we have a second diagnosis, likely cervical high cell SYN3, and we rang the clinicians and suggested further investigation.
Okay.
Yeah.
All right. Mm, mm.
Anyone else got questions or comments or seen something similar? Have you ladies in Vietnam seen any nasty SCC cases like that?
Yes, yes. In Vietnam, we have a lot of case of cervix cancer, and we see many case of SCC and adenocarcinoma of the cervix. And fortunately, we have a P16 as well, so it helps us a lot in diagnosing about the origin of the cancer from the cervix on the endometrium. And we have a panel to stand. We usually stand visiting, dimenting, CER, ER, PR to help diagnose the origin from the cervix or the endometrium.
Can
I
you
wondered
do
if that's
HPV? Oh,
sorry, go ahead, Deb.
sorry, I was just going to ask, can you do HPV in situ hybridization in Vietnam? Do you have that?
Yes, we have. Our department have a SPV DNA test, and we do it in SPV compact machine.
Nice, you're doing better than us.
Yeah.
We used to have it, but now that we don't do gyne-cyto anymore, we don't have it. And actually, I don't think anywhere in New Zealand has the HPV-ish, and it's a very, very useful test. So I miss it.
One question, Dr. Rachel. It's me, Una. If we have a HPV-16 P16 test in Fiji, would we be able to tell us if it was seen or things like that before we even plan out her surgery? Even though patient herself doesn't have like a fungating lesion, because the post-hysterectomy histology now is saying that it's a cervical lesion. Like we could have done a radical hysterectomy, but instead we just did a simple because of what Viri reported earlier.
Because you thought it was, a nasty
Yeah.
endometrial cancer, right? Yes.
Yes.
So it's the immunostain's got a slightly confusing name because it's called P16. And yes, if you've got HPV-16, it should light up, but it also tests for a number of high-risk HPV genotypes. But yes, if you could have done it on that biopsy, and that would have given you a good clue that it was HPV associated and maybe cervical. Or if she'd had the other thing, if you're thinking of that, is you could do, you did have HPV testing, didn't you? Or have you run out of kits now for your cyto? Oh, you're mute.
Sorry, we've started doing the HPV screening now.
Yeah, so that's what you could do. At the time of the PROPEL, you could also do an HPV test, which would be really helpful, because if you got that biopsy and a positive HPV test, you could put that information together and go, actually, maybe it's cervical rather than endometrial.
I think that's really tough still though, because your HPV is common. Your cervix looked normal, felt normal. The uterus is bulky. The biopsy showed a really poorly differentiated tumor. So I think realistically that is always going to be very difficult. And it happens to us here. We get the same thing sometimes with those very high tumors, because clinically, it's very hard to know what's going on. Possibly the one thing that will make a difference that you may not have in Fiji is markers to show that it's squamous, not glandular. Like here, if we have immunochemistry for CK5 or P40, we can put those stains on, know it's squamous, and that then brings up that differential that went through at the end. And with that differential, you know that it's highly likely to be from the cervix, not the endometrium, just because statistically that's more common. But without that and without the morphology, I think it's just like one of those life events that happens.
Once a tumor gets so poorly differentiated, quite hard to tell.
Another thing that is a bit of a red flag, it's not so applicable in this case, but when you've got a tumor you think's an endometrial primary and in the endometrioid family, if you've got absolutely negative staining with hormone receptors, that's always a reason to stop and think about other possibilities. You don't always think about cervix primary in that setting, but you think about unusual endometrial primaries like clear cell carcinoma or mesonephric-like adenocarcinoma or gastric type. None of those were on the cards here, and you could argue that the negative ER-PR is just a function of this being a poorly differentiated endometrioid if it were an endometrioid adeno. So it's not a perfect sort of setting to make that argument, but just in general terms, when you're working up an endometrial adenocarcinoma and you think it's endometrioid in type and the ER-PR are completely flat negative, you really do need to stop and think about what else could this be.
Awesome, everyone. Thank you so much. Just real quick, last time we had Ven sign up for January. Are you still good to go for January, Ven?
Yeah. In the next time, it's in my window home, and I am looking for a case that have a unresolved question.
Okay, great. And then if you need help from one of our mentors, we can also connect you with one of them. And then secondly, has everyone like been able to log on to the open website and access the first gyn pathology module?
Yes, I have logged on,
Yes.
trying to do it.
Okay. If you have any questions about how to access it, how to get on there, or if you run into any issues, go ahead and send me an email, and we can get that worked out. But
Can I
otherwise,
highlight, sorry, one tip that my son showed me last night, which may be obvious to everybody else, but because we're kind of all older. So I'm looking at the videos and I'm on the open website and you can't screen backwards and forwards. But he did show me that if you click on the little YouTube logo, it takes you through to YouTube. And then it's great because you can speed it up, you can slow it down, you can screen backwards and forwards through the video. So it makes it much easier to go back to where you started, much easier to go back if you missed something. Yeah, just thought I'd share that because it took my 15-year-old to went
Thanks,
down.
Deb.
Thanks for the tip.
well, awesome. Well, thanks everyone. Have a very Merry Christmas and Happy Holidays, and see you in January.
Merry Christmas, Happy New Year.
Merry
Bye, everyone.
Christmas. Thank
See you
you.
later.
Bye.
Thank you,
Bye.
Felicity.